Hey everybody, and this is your respiratory system pre-lecture video. So for the respiratory system, it's about 2.5 lectures worth of material, but we really only have room in the schedule to spend 2 lectures on it, at least not without removing some of the review days that we have scheduled in for Bio 33. So I think it's really important that we do have review days where we don't learn any new material before the exam. So in order to be able to accomplish that, we do a pre-lecture assignment for the respiratory system so that you essentially learn the anatomy on your own the weekend before we do respiratory 1, and then when we get into class for lecture for respiratory 1, we get right into it with the physiology, and then we should have enough time to finish respiratory 1 and respiratory 2 in those 2 lectures. So it's a little bit work on your end, but I think it's worth it to have that review day embedded into the schedule. Okay, so here we go. And I have a meeting background on, but we're just going to go with it. Okay, I think now you should be looking at my screen. Okay. So actually I want to switch the screens. Give me a second. Pull this up. This is how I like it. Okay. So here we go. And make sure I'm still sharing the right thing. Yes. Okay. So the lecture objectives for respiratory 1, or at least the pre-assignment for respiratory 1, is to describe the location, structure, and function of each, the nose, paranasal sinuses, and the pharynx. We'll list and describe several protective mechanisms of the respiratory system. We'll talk about conducting and respiratory zone structures. We'll talk about the function, structure, and location of the larynx, trachea, and the bronchi. We'll talk about the respiratory membrane and relate structure to function. And we'll talk about the organs forming the respiratory passageways in descending order until we reach the alveoli. And then we'll talk about the gross anatomical structure of the lungs and pleura. Okay, so the main function of your respiratory system is respiration. And what we mean by respiration is getting the oxygen from the atmosphere and essentially delivering that to the tissues. And then on the opposite end, from the tissues, picking up the CO2 from the tissues and then eventually breathing it out through our lungs. In order to accomplish that, though, there are 4 different processes that have to happen. First is the actual act of breathing. Now that we're into the respiratory system, you have to call that pulmonary ventilation. So ventilation is the movement of air using the lungs. So ventilation consists of both inspiration and expiration, also known as inhalation and exhalation. But inspiration is going to move air into the lungs from the atmosphere, versus expiration or exhalation, which is going to move air out of the lungs back into the atmosphere. The next step is external respiration. And whenever we talk about respiration in this sense, we're talking about the blood. So we're talking about oxygen from the air that we breathe in, which diffuses into the blood at our lungs, and then the CO2 that diffuses from the blood back into the lungs so that we can eventually breathe it out through exhalation. Then after external respiration, which is basically just the exchanges of those gases at the pulmonary capillaries, after that external respiration is the transport of respiratory gases. And so the transport of respiratory gases is going to be carried out by our cardiovascular system. So our cardiovascular system and our respiratory system work very, very closely together. So again, once we do exchange those gases at the pulmonary capillaries, it is up to our cardiovascular system to then transport those respiratory gases throughout the body. So you can see the textbook tells you that the cardiovascular system transports gases using blood as a transporting fluid, O2 is transported from the lungs to the tissue cells of the body, while CO2 is transported from those tissue cells back to the lungs. And we'll do external respiration and then eventually exhalation to remove it. And then we have internal respiration. Internal respiration is when oxygen diffuses from the blood into our tissue. So basically we are delivering that oxygen to our tissue cells. That is internal respiration. And then within the cell will use that oxygen to then do cellular respiration. And then CO2, still part of this internal respiration, is that CO2 diffuses from the tissues because it is a waste product of tissues, is going to take that CO2 from the tissues and then put it back into the blood. So if we're going to be talking like in steps as far as oxygen and carbon dioxide, so let's talk about oxygen first. Oxygen comes in through inhalation or inspiration, whichever term you want to use, but oxygen comes into the lungs through inspiration, and then oxygen will diffuse into the blood through external respiration. Then the cardiovascular system will then transport that blood, that oxygenated blood, through the left side of the heart, and then eventually take that out to the capillaries that are tissues, and then through internal respiration, the oxygen will diffuse into those tissues. And then for CO2, in order for us to get rid of it, we're going to take those steps and go in the opposite direction. So I use internal respiration here for that CO2 to diffuse into the blood. We'll use the venous side of our systemic circulation to allow the cardiovascular system to then transport those gases through our blood. And then through the right side of the heart, we'll take that deoxygenated blood that now has CO2 in it back to our lungs and allow external respiration to occur, where that CO2 will diffuse out of the blood into the lungs. And then we'll use expiration or exhalation, which is one of our ways to do pulmonary ventilation, in order to breathe that CO2 back out into the atmosphere. So those are our 4 processes of respiration. We'll take that process downward for oxygen in order to deliver that to the tissues, and then we'll go upward in this direction with CO2 in order to vacate that CO2 through our lungs. Okay, so the first key concept is that the upper respiratory system warms, humidifies, and filters air from the nose to the pharynx. So these are all the different respiratory structures that we're going to talk about eventually today, and more than that actually. But we're going to start with the nasal cavity and the paranasal sinuses. So the functions of the nose and paranasal cavities and sinuses is that, one, it filters, warms, and humidifies inspired air. We are able to filter the air that comes in through the hairs that are within our nose. And we're able to warm that air through the mucus lining our nasal cavity. And because that is mucus and it is moisture in there, it also is going to humidify the air that's coming in. If you remember from the skeletal system, we do have paranasal sinuses. So we have the frontal ones here. And then within our skulls, we have the ethmoidal sinuses, our sphenoid sinus, and then our maxillary sinuses as well. And we'll talk a little bit about those in relation to sinus infections and sinus headaches a little bit later. But one of the functions that those sinus cavities do for us, or those paranasal sinuses do for us, is they are a resonating chamber for speech. So it allows us to project our voices, which is why when we do have a sinus infection and those sinuses are filled with fluid, it makes our voice sound very muffled, and it's harder for us to project our voices. Because you change the structure, you change the function. And these sinuses are meant to be empty, hollow. And so that hollowness allows us to project our voices, but if they're filled with fluid, then they're not going to do their jobs as well. And then the last thing for functions is that it houses olfactory receptors. If you remember from Bio 32, olfactory receptors or olfactory nerves are for sense of smell. And so those olfactory receptors are a specific type of receptors. And if we were live in class, I would ask everybody, what type of receptor do you think that is? And it's going to be detecting things that allow you to smell. So chemicals coming into, well, chemicals, I already said it, but chemicals coming into your nose from whatever's around you that's creating that aroma. And those would be chemoreceptors. So chemoreceptors are going to be within this olfactory epithelium here, lining the top of our nasal cavity to allow us that sense of smell. Some of the external structures that you are responsible for are the bridge of the nose, which is going to be right there at the very top. The apex of the nose, or you can also call it the tip of the nose. Either one is fine, but your book uses apex, which is more of a scientific term anyways. Scientifical, more of a scientific term. And then your nares. So your nares are your nostrils. Nares is a singular one, but if you're talking about both, they're called the nares. Another structure you're responsible to know is the nasal septum, which is the wall that separates your nasal cavity on the left and right. You should remember from Bio 32 again that septum, although most of it is cartilage right there in the front, because you can wiggle it around, most of that is cartilage, but towards the posterior side of the nasal cavity, it is separated by bone. So that nasal septum is made up of the perpendicular plate, which is part of the ethmoid bone, and then the vomer on the bottom, which is its own bone. And then one other function of the nasal cavity is that it actually directs that air towards what's called the nasopharynx. So we'll talk about it a little bit later, but our throat is separated into three sections: the nasopharynx in the nasal cavity, the oropharynx in the oral cavity, and then the laryngopharynx right behind the larynx. And so the nasopharynx, oh, I guess you could say the nasopharynx is behind the nasal cavity, oropharynx behind the oral cavity, laryngopharynx behind the larynx. But anyways, the nasal cavity is going to direct incoming air towards that nasopharynx. And then other structures that you need to know as far as the nasal cavity goes is that the top of the nasal cavity, you should already know, is made up of our ethmoid bone here and then our sphenoid bone here at the back. So our ethmoid and sphenoid bones make up the roof of our nasal cavity, but the floor of our nasal cavity is made up of the hard palate. If you remember from Bio 32, it's made up of part of your maxilla called the palatine processes, and then the actual palatine bone behind that. And I'll show you that in the next slide. But know that it's made of your maxilla and your palatine bone. And then your soft palate back here, that is a muscular piece of tissue, but the end of that muscular piece of tissue called the soft palate, which is the bottom of the nasal cavity or the floor of the nasal cavity, is called the uvula. So the uvula is that little hangy thing at the back of your throat, which is basically the end of the soft palate. So again, your hard palate is made up of your palatine processes of your maxilla, which are these two purple pieces here, and then your palatine bone in the back. Now, one thing that's mentioned in your lecture notes is a clinical application about a cleft palate. So a cleft palate is basically like during development, when these three pieces of bone do not fuse together properly, your palatine bone and then these two palatine processes, when those three pieces don't fuse together properly, they are left with something called a cleft palate. And this is occurs in infants. So you can see how those bones did not fuse together at the roof of the mouth, or the you can also say the floor of the nasal cavity. So when they don't fuse fused together, you have a cleft palate. Now, sometimes that can also make a cleft lip. So if that fusion doesn't happen all the way through to the front, you can also have what's called a cleft lip, where the lip is separated because those bones did not fuse together. But your lecture note only mentions a cleft palate, not a cleft lip. Next is the respiratory mucosa. Now, in your text, in your lecture notes, and I want you to go ahead and cross something out for me. It says, your lecture notes say respiratory membrane, and then mucosa in parentheses, if I can type mucosa in parentheses. What mucosa. What I want you all to do right now really quickly for me is in your lecture notes, if you have that written in your lecture notes, and you do, what I want you to do is I want you to take a pen, I want you to cross off respiratory membrane. Now, I'm not sure why whoever wrote that, so cross off membrane. It's just the respiratory mucosa. We're going to talk about something else called the respiratory membrane a little bit later. Now, they may have called it the respiratory membrane because it is a mucous membrane and it is lining your respiratory tract. But I don't want to confuse you all because we will be talking about a respiratory membrane towards the end of this pre-lecture. So just call it the respiratory mucosa. It is a mucous membrane and it is a part of your respiratory system, but this is not the true respiratory membrane. Just call it the respiratory mucosa. So the mucosa that we're referring to here is this top layer of the walls that make up our respiratory tract. And you should know that that's made up of pseudostratified ciliated columnar epithelium. That is the tissue type that makes up the lining of most of our respiratory tract. I'll talk about different places in the respiratory tract where it's different, but most places you're going to have pseudostratified ciliated columnar epithelium lining your respiratory tract. But again, I'll tell you the places that we do have it and then the places that we don't have it. I will say for now, what we've talked about so far, your nasal cavity is lined with that pseudostratified ciliated columnar epithelium. Okay, I think that's all I want to say on that slide. You don't have to know all the layers of the respiratory tract, like the mucosa, submucosa, and adventitia. We're actually going to talk about that when we get to the digestive system. We'll talk about layers of the GI wall. Oh, one other thing I did want to mention too is your book mentions another clinical aspect called rhinitis. Rhinitis is simply inflammation of that respiratory mucosa. So when that tissue gets inflamed, that is rhinitis. Respiratory mucosa. And specifically in the nasal cavity. And so we can say the nasal mucosa. So that's rhinitis. Rhino is referring to the nose. So it's inflammation. I guess we could just say that. Inflammation of the nasal mucosa. It is going to cause, if you have rhinitis, it's going to cause excess mucus production. So you may have like a runny nose, like I do right now. It's my allergies. But excess mucus. So you'll have excess mucus production. You can have nasal congestion. And then because of the nasal congestion and excess mucus, you may have a post-nasal drip, which is not fun. I mean, you can feel stuff going down the back of your throat. And so this respiratory mucosa goes from our nasal cavity to like down our throat to our trachea and all the way down to our bronchi. And so because this respiratory mucosa is all continuous, is why when you get a cold, because rhinitis, this inflammation of the nasal mucosa, is most of the time caused by a infection, like a viral infection for the most part. This is why colds progress from the nose to the throat, and then eventually to the chest. Because if the mucosa in the nose is infected and then it's not treated, all of it's continuous as it goes down your respiratory tract. So then that infection and that feeling of sickness will go from your nose to your throat and then eventually to your chest if it's not treated quickly enough. Rhinitis, because your nose and your paranasal sinuses are connected, it can lead. So an infection in the nose can lead to a infection of your paranasal sinuses. It can lead to sinusitis, which again is inflammation of your sinuses or your paranasal sinuses. And a lot of times when you get sinusitis, where your sinuses, your sinus cavities are filled with fluid, like I said, remember, it makes your voice muffled and your paranasal sinuses can't do their job correctly, which is just to project your voice and be a resonating chamber for speech. If you do have rhinitis that leads to sinusitis, because those areas fill with pressure within the skull, it can lead to an increase in sinus pressure, which can then lead to a sinus headache, and those are not fun. But that is rhinitis. Okay, and then the next slide is just showing you a electron micrograph of that pseudostratified ciliated columnar in the trachea, and you can see the hairs of the cilia. This is at 2,500 times magnification, so much stronger than any of the microscopes that we use in our lab. Next, I do want to mention, I know this is not the prettiest picture, but this is the only one that actually mentions the concha and the meatises together. So the nasal concha, you should remember from Bio 32 from the skeletal system, that the nasal concha are the bony projections within the nasal cavity. So you have your superior up here, your middle nasal concha, and then your inferior nasal concha. And then I'm going to draw. They are lined with that respiratory mucosa, and they wrap around those nasal concha. So there's a groove underneath each one of those, and each one of those grooves is called a meatus. So you have a superior nasal meatus, you have a middle nasal meatus, and then you have a inferior nasal meatus. And so you should know the difference between concha and then our meatuses. So again, the nasal concha are the actual bony projections, and then the meatuses are the grooves underneath those projections. Okay. So now we're going to move on to the pharynx. The pharynx is more commonly known as the throat, and we do have 3 sections of it. We have the nasopharynx at the top, which is going to be not up here, that's your nasal cavity. Back here, which is going to be your the back of the nasal cavity, which is the nasopharynx. The back of the oral cavity is called the oropharynx, and the back of the larynx is called the laryngopharynx. So, let me erase all this stuff. So the terms that you are responsible for when it comes to those 3 sections of the throat or pharynx, the nasopharynx has the pharyngeal tonsil at the top of the nasal cavity. That's a lot of times referred to as the adenoids. So you'll get your tonsils, which is usually your palatine tonsils, and then your pharyngeal tonsils removed if you had both your tonsils and adenoids removed. So that's what they mean when they're talking about having your tonsils and adenoids removed. Is usually your palatine tonsils at the back, and then your adenoids or pharyngeal tonsils at the top. You should already know your pharyngotympanic tube, also known as the eustachian tube. It is the tube that drains your middle ear down to your nose. And you can't see the actual tube here. This is just the opening to it. But if you remember from the ear model from Bio 32, there is that pharyngotympanic tube draining the middle ear. Then you have your fauces. This is the isthmus of fauces, which is basically just the opening at the back of the throat there. And then also your palatine tonsil, like I mentioned before. And then you do have another tonsil right behind the tongue, which is called the lingual tonsil. And then your laryngopharynx, again, is the area behind the larynx. You should know that both the oropharynx and the laryngopharynx are made of stratified squamous. Your nasal cavity, like I said before, your nasal cavity is pseudostratified. Where's the F at? There's pseudostratified, ciliated, columnar, epithelium. So that's in your nasal cavity and nasopharynx. Once you get to your oropharynx and your laryngopharynx, those are areas that are going to come in contact with food. So the things that you eat, sometimes we're eating very hard things, or very like rough things or pointy things like Doritos for one instance, chips, and things like that are kind of pokey, sharp. You want extra protection and extra layers of tissue as the food is moving down your throat. So both your oropharynx and your laryngopharynx are made of stratified squamous epithelium. And if you remember from Bio 32, it's layers upon layers of flat cells. And again, that provides extra protection for the areas that are going to come in contact with food. Okay. So that was the upper respiratory system. Now your lower respiratory system consists of conducting and respiratory structures. So we have a conducting zone and then the respiratory zone. But we'll get into that in a second. So the first part of your lower respiratory system is the larynx. So you have your thyroid cartilage, which part of your thyroid cartilage is there is a pointy portion of your thyroid cartilage called the laryngeal prominence. And so your laryngeal prominence is commonly referred to as your Adam's apple. Do not use Adam's apple on the exam. You're going to use the laryngeal prominence because that's what it's called scientifically. So again, do not call it the Adam's apple. I'll probably only give you like a quarter of a point on a practical if you were to tell me Adam's apple. It should be the laryngeal prominence, which is just the projection. So it's just the point that comes to, or just the portion that comes to a point at the very front. That is the prominence. And then you have your cricoid cartilage. So you should know that both your thyroid cartilage and your cricoid cartilage, these are both made from hyaline cartilage. And that is review. That is from Bio 32. All of your respiratory cartilages are made from hyaline cartilage. Some of the functions listed in your lecture notes for the larynx is that it provides an open airway for air to come down and eventually reach the lungs. It is a switching mechanism to route food and water to the esophagus, and that's going to be done by your epiglottis. So this little thing up here, or up here, this little thing up here, the epiglottis, what it does is it will fold itself back whenever you swallow to cover up the trachea. So that your food goes down your esophagus in the back and not your trachea in the front. And I'll show you that, I think, on the next slide, the one after that. This is a image of a person. That way you can see that laryngeal prominence through the skin. That is the Adam's apple. You should know that everyone has a laryngeal prominence, even me. All humans do. It's just that males who have more testosterone happen to grow that particular part of the body more. So the more testosterone you have, the larger your laryngeal prominence is going to be, but everyone has it. Everybody's thyroid cartilage comes to a point. It's just more prominent in males because of their levels of testosterone. Okay, before we get to the epiglottis, we have the glottis. So your glottis is essentially just the opening into the trachea. So it's really hard to tag on an exam because we don't really have a model that looks down into the throat. Oh, actually we do have one. I'll probably have to bring that out and put it at the front table. But we do have like a standalone trachea and you can look inside, or actually a standalone larynx and you can look inside through into the glottis. And then you have what are called your vocal folds, which are these shiny white ones right here. I don't need you to know the difference between your true vocal cords and your false vocal cords. Don't worry about that. Just know your vocal folds or vocal cords are those white shiny ones there. One thing I did want to say about your glottis and those vocal cords or vocal folds is that your textbook, or not textbook, but your lecture notes mentioned something called the Valsalva maneuver. And the Valsalva maneuver is just the closing of that glottis. So you use your vocal folds to close the glottis, and then you engage your abdominal muscles, and then you can use that, and you can use that for heavy lifting. So if you're a weightlifter, or you just need to lift something, a heavy box or what have you, you can engage your core, close up your glottis so the air is not moving, and then use that intra-abdominal pressure and the strength of your that internal cavity in order to lift that particular box or weight. Or it's also used for bowel movements too, for defecation. You really shouldn't strain when you defecate. If you're drinking enough water, you really shouldn't strain at all. But if you need to, you can again close up that glottis, engage your core, and you can create an intra-abdominal pressure that will help give you that extra bit of force or strength that you need to either lift or defecate. So it's just that's the Valsalva maneuver. As far as like tissue types go for the larynx, if you are above the glottis, it's going to still be that stratified squamous. Again, anything below the nose but above the glottis, because food can come in contact with those places, it's going to be stratified squamous epithelium. I'm not going to write epithelium because I just want to take up more time, but I guess I'm just going to put it epi. Stratified squamous epithelium. Below the glottis, because below the glottis, it really should not be any food there unless it's on an accident. But there really should not be any food going through below the glottis. So then now we can just continue on with our respiratory mucosa, which is going to be pseudostratified. And I'll make this bigger. I'm gonna need more room. Pseudostratified ciliated columnar epithelium. Okay. One other thing that's mentioned in your lecture notes as far as a clinical note goes is laryngitis. Laryngitis is specifically inflammation of the vocal folds. The inflammation of the vocal folds. And if you ever had laryngitis, you know that because it is inflaming those vocal cords and swelling them, it does make your voice hoarse. It's going to basically change the tone of your voice, because if you change the structure, you change the function. So if your vocal folds become inflamed, now the structure is going to be different because now they're going to be swollen and irritated. Your voice may become hoarse. So you'll have a raspy kind of voice. And then it can lead to you only being able to talk in a whisper because of that inflammation. It's like talking like this because you've lost your voice. Okay. This can be caused by, so causes include infection, obviously. A lot of times with inflammation, it's due to infection. Overuse of your voice. So if you're a singer or somebody who talks a lot, like a teacher like me, overuse of your voice can cause laryngitis. If you live somewhere that has very dry air, or you suddenly travel to somewhere with very dry air and you're not used to it, it can cause laryngitis. Inhaling harsh chemicals can also cause laryngitis. And then the last thing I'm going to mention is if you have a tumor that's placed on your vocal folds, then you can also develop laryngitis. So that is all about that particular clinical note. So here is, I wanted to show you that epiglottis. So this is the epiglottis here. This is the opening to your trachea. So if you're looking down, that would be the glottis. And then your esophagus is back here behind it. So what happens is that this epiglottis is going to bend downward here, and it's going to cover the glottis. And that's going to allow food to then travel down the esophagus rather than go down the trachea. So it's a protective mechanism. So each time you swallow, the epiglottis bends downward and food goes into your esophagus. And we'll talk about that more when we get to the digestive system. Oh, one other thing I wanted to mention about the cricoid cartilage. The cricoid cartilage is the only complete ring of cartilage around the trachea, or above the trachea, I guess. But on that tube, right, it is the only complete ring of cartilage. Your thyroid cartilage is only on the front. There's no thyroid on the back. And then your C rings of your trachea, they're only C's. They don't go all the way around. You have a muscle at the back of the trachea instead, and I'll explain why that is in a little bit. Or right now, because we're now on the trachea. So the trachea is this tube here past the larynx that we just talked about. One thing I wanted to mention about the trachea that I said before is that it's made up of C rings, so that's not a complete ring of cartilage. And there's a muscle in the back called the trachealis. The reason why we have that muscle is because here's our esophagus right behind the trachea. So if we were to eat something particularly big and it go down our throat, this may stretch a bit. And so you don't want that stretching to be pushing up against hard cartilage. If it's pushing up against muscle's going to have more give, and so it's going to be easy to work with when food is going down the esophagus. So it's not pushing up against a hard material, but more of a soft material. Oh yeah, and then now that we're in our trachea, so like I said, anything below the glottis is still going to have that pseudostratified ciliated columnar. So you can see a little cilia there, but that's going to be your pseudostratified ciliated columnar. One clinical aspect I do want to mention is that when you are a smoker, a tobacco smoker, the smoke and the not the smoke, but the nicotine within the tobacco smoke can actually paralyze the cilia and make it hard for smokers to use smokers to cough up mucus. So one of the tissue types you're going to look at for the respiratory system lab is going to be the smoker's lung tissue. Now, it's a review. You've seen smoker's lung tissue in Bio32 when you went through the tissues chapter, but now that we're talking about the respiratory system, it's relevant here too. So the smoker's lung is that piece of lung tissue that you've seen under the microscope before that has the black tar deposits due to the smoking habit. One of the other effects of smoking, again, is that nicotine paralyzes cilia. Cilia in your respiratory tract is meant to move mucus up your respiratory tract so that you can eventually spit out the mucus and get rid of anything bad that was trying to enter your body. And so people who smoke and the nicotine paralyzes their cilia and their cilia don't move, well, then their mucus isn't going to go anywhere because that cilia cannot beat and move that mucus up the respiratory tract. So they can cough and all day, but they're going to have very little mucus production, if any at all, because their cilia do not work. The cilia are the one that move the mucus, and so if they're paralyzed, they're not going to be able to move the mucus at all. Okay. One thing about the trachea you should know about is the bifurcation of the trachea. Bifurcate just means to split into two, like vessels bifurcated as well. Arteries bifurcated when we talked about arteries and vessels, but it's the bifurcation of the trachea. So when the trachea splits into two right there, that area is called the carina of the trachea, and it is highly innervated. So there's lots of nerve endings at the carina or right on the chest at the carina. And if food were to accidentally go down the wrong pipe, so let's say your epiglottis here failed let's say it only closed that way and food was able to enter and go down the trachea and food touched that carina at the bottom, because it's so highly innervated, you'll immediately start to cough, and it's a spastic cough, like you can't control it. You're not coughing, your body's coughing for you, and it's to try to expel whatever it is that came into your trachea that didn't belong. So as soon as something touches that trachea or that carina of the trachea, it's going to be a reflex for you to start spastically coughing in order to try to get rid of that thing that was able to get down in there. And because we're still in the trachea, we are still going to be dealing with pseudostratified ciliated columnar epithelium. One other clinical note that's mentioned in your lecture notes is the Heimlich maneuver. So whenever the Heimlich maneuver is done, and you can't really see me, but where they like push up against your abdomen and upward towards your lungs. The reason for that is it's because it's using air trapped in your lungs in order to push and eject that foreign object out. So it uses the air that's already in your lungs, push it up, and allow that air to forcefully push that object out. Hopefully you spit it out and you don't choke. So let's see, where are we at? Oh, so the conducting zone. So you have what's called the conducting zone, and then you have the respiratory zone. So your conducting zone is going to be the areas that are going to be conducting the air. So it's going to be your trachea, and then you have your primary bronchi. So your primary bronchi, the first branches. So when the trachea bifurcates into these tubes here, those are your primary bronchi. A bronchus is a single, so you have a left primary bronchus and a right primary bronchus, but those are bronchi. Those are still going to have your pseudostratified ciliated columnar epithelium. Now from there, because if you remember, your alveoli have simple squamous. This is where gas exchange occurs. So you really only need a thin layer of flat cells because you want gas exchange to occur very fast. So your alveoli, which are at the very end of this pathway, have simple squamous epithelium. But right here at your main or primary bronchi, and call them primary, but at your primary bronchi, you're going to have pseudostratified ciliated columnar epithelium. Oh, I guess I put epi. It's really long. But your primary bronchi will have pseudostratified ciliated columnar epithelium. And at the very, very end, you'll have simple squamous epithelium. So it's not, you can't really go from your pseudostratified straight to simple squamous. There has to be kind of a transition. I'm not going to make you know the transition, but essentially you go from pseudostratified ciliated columnar to a simple columnar, then to a simple cuboidal, until eventually you reach the alveoli with a simple squamous epithelium. I won't make you know all those different tissue types. Know all the ones I've talked about so far, and know that it's going to continue to be pseudostratified ciliated columnar epithelium till we get to our primary bronchi. And then you don't have to know any of the tissue types going forward until we get to the alveoli, where we're going to be at simple squamous. So you don't have to know the tissue for your secondary bronchi or your tertiary bronchi or your terminal or respiratory bronchioles that we'll talk about here in a second. Okay, so just know that we end our pseudostratified ciliated columnar here in the primary bronchi, then it transitions for a little while through structures until we get to the alveoli that have simple squamous. Okay, so back to naming these bronchi. So you have your primary bronchi, which are these first branches coming off. Then you have your secondary bronchi, which are, you're going to have 3 secondary bronchi on the right, 1, 2, and 3. And you're only going to have 2 secondary bronchi on the left, 1 and 2. The reason for that, and we'll talk about more of that reason later, is that there are 3 lobes on the right lung and 2 lobes, I guess I should say of of the left lung. The reason is because it's to make room for the heart. We'll talk about that a little bit later. But you have 2 primary bronchi. You have 3 secondary bronchi on the right, 2 secondary bronchi on the left, and then you have many tertiary bronchi. So your tertiary bronchi are all of the branches that come off of those. So all of these would be considered tertiary bronchi. Those are all tertiary bronchi. There's many of them. So again, I'll say this again. You have 2 primary bronchi on each side. Two primary bronchi. You'll have 3 secondary on the right and 2 secondary on the left. And then you have many tertiary. And these are your bronchi. Okay. Another thing I want to mention about these bronchi is that your primary bronchi here for your primary bronchi, and I'll write the note over here. Your primary bronchi lumen is equal to the size of a peanut. So this makes the primary bronchi it's basically a choking hazard. So if the diameter of your primary bronchi is just the size of a peanut, that means that things can get stuck in there. Anything that's larger than a peanut or the size of a peanut would essentially get stuck. And so one thing, when we talked about our 4 different processes of respiration, we have ventilation, external respiration, the transportation of those gases, and then internal respiration. Now, if ventilation is messed up, if there's an interference or a disruption in ventilation, that means that all 3 of the processes down from that are not going to work. So if you were to get a peanut stuck in your primary bronchi, your first step or your first course of action should be to restore ventilation, to get that person to breathe again. Because if that person can't do ventilation, then they're not going to be able to do external transport or internal respiration anyway. So the primary focus should be to restore ventilation, to do the Heimlich remover and remove whatever that foreign object is that is lodged in that bronchi or bronchus, if we're talking about one. I think that's all I want to say about that. Okay, I think we're good there. So I'm going to erase all this. So if you need to still write stuff down, pause the video. I'm going to erase now. So after your tertiary bronchi, then the tubes are going to get smaller and smaller. Once the tubes are less than 1 millimeter, they're now called bronchioles, which are essentially small bronchi. Okay, so if it's less than 1 millimeter in diameter, it's going to be considered a bronchiole. And then those bronchioles are going to divide and get smaller until we reach what's called a terminal bronchiole. Terminal bronchiole is even smaller. It's less than 0.5 millimeter, are terminal bronchioles. But then terminal bronchioles are then going to branch off into respiratory bronchioles. Now, a lot of people get this mixed up. Terminal is not the last one. You have terminal bronchioles and then the respiratory bronchioles that are going to approach where our internal respiration occurs. Okay, so terminal is not the last one. Terminal is second to last. And then you have respiratory bronchioles. And then from there, it's going to create a little tube here called the alveolar duct. And the alveolar duct is going to attach to an alveolar sac. So this is an alveolar sac. An alveolar sac is essentially like a bunch of grapes. So if you have I'm talking about like bunches of grapes. So if you have a bunch of grapes, that's an alveolar sac. Each alveoli or each alveolus, so each one of these individual things are individual grapes, and those are alveoli. If we're talking about one individual grape, it's called an alveolus. Okay. So as you can imagine, there is going to be a tracer drop on this. So there's going to be a pathway that you should know that you're going to find out when we get to respiratory 1 in lecture. So we've learned about all these structures that make up our respiratory tract. The alveoli, these individual little grapes here, that's the end of it. That's where gas exchange is going to occur, which is what we're going to talk about next. So as far as like the conducting zone though goes, as far as the pathway for this goes, I can go over that really quickly. I hope I spelled that right. It looked kind of off when I just erased it, but bronchioles should be like this. If I spelled it wrong, I don't know if I did, but it should be like that. Anyway, so for the pathway, starting from the conducting zone back here, so it's going to be your trachea to your primary bronchi to your secondary bronchi, 2 on the left, 3 on the right, then your many tertiary bronchi, and then those will branch and get smaller and smaller and smaller until they're less than 1 millimeter, which is when they become bronchioles, and those bronchioles will divide until you get to terminal bronchioles. Those terminal bronchioles will transition to respiratory bronchioles. Those respiratory bronchioles will then make these little tubes called alveolar ducts. Those alveolar ducts are going to supply each one of the alveolar sacs, which are bunches of grapes. And then each one of the individual grapes is called an alveolus. If we're talking about multiple of them, they're called alveoli. If you need to pause or rewind that, you can do so. Okay. And as we get farther and farther down this respiratory tract and get closer to the alveoli, there's going to be less mucus and less cilia, because now we're going to be approaching where gas exchange occurs. You don't want a bunch of mucus getting in the way when we're trying to exchange gases. So the exchange of gases is going to happen at the respiratory membrane. So this is why I didn't want you to call the last thing the respiratory membrane. That's respiratory mucosa. This is the respiratory membrane. And so the respiratory membrane is when the capillaries line up with the alveoli in order for that gas exchange to occur. So I'm going to show you that on the next slide. So here's the respiratory membrane. So your respiratory membrane is essentially the simple squamous epithelium of the alveoli. So remember, again, this is where I want you to know again what the tissue type is. Each one of these air sacs is going to have simple squamous epithelium. So the respiratory membrane is where the alveolus, the wall of the alveolus, which is made up of alveolar epithelium, lines up with the capillary, the endothelium of the capillary, which is that tunic that makes up our capillaries. Remember, it's only a thin layer of your tunica intima called the endothelium. But where those two come together, that is the respiratory membrane. Okay, so here, respiratory membrane is your alveolar epithelium and your capillary epithelium, which is called endothelium, and the fused basement membranes of the two. Okay, that is your respiratory membrane. And that is where gas exchange is going to occur. This is where internal respiration, or sorry, not internal, but external respiration occurs. So this is external respiration where we're going to take the air from the lungs and diffuse it into the blood. Again, this is external respiration. And then the CO2 we're going to take from the blood, put it back into the alveolus so we can breathe it out back into the atmosphere. One thing you'll notice here, we're going to talk about this more later, is that we have a couple different types of cells within these alveoli. You have type 1 alveolar cells. These are going to be important in gas exchange. So those are where the movement of oxygen and carbon dioxide occur. You have your type 2 alveolar cells. Those are going to secrete something called surfactant, which surfactant, actually, what it does, it creates a thin layer. So surfactant is going to layer inside this alveolus. And what it does is it reduces the surface tension within that alveolus. And what that means is that it makes it so that the water that cavity is not attracted to each other. So it's going to reduce the surface tension so that when air vacates the alveoli, because the alveoli are going to bring in and take out air all day long. So when it kind of deflates a little bit and air is removed, it's not going to collapse on itself. So that surfactant keeps those alveoli nice and big and open, reduces the surface tension so the walls are not attracted to each other, so it doesn't collapse when air is removed from them. You're also going to have macrophages around as well to clean up any cell debris or anything that does not belong. You should already know there are our cleanup crew. There are little Pac-Men that can go around and clean up things that don't belong. So you should know the types of cells that we're going to find within these alveoli. Okay. Last little bit is on the gross anatomy of the lungs. So each multi-lobed lung occupies its own pleural cavity. And so there's going to be a little bit of review as well. So like we said before, you're going to have 3 lobes on the right side, 2 lobes on the left side. And so for the right side, where we have 3, we're going to have a superior lobe, a middle lobe, and an inferior lobe. So remember, middle and medial mean 2 different things. Medial means towards the midline of the body. Okay, that's what that means. It's a directional term. The middle lobe, it just means it's in the middle of superior and inferior. It's not towards the middle or yeah, so it's not towards the middle of the body. That's not what that means. It's just in between 2 other structures. And then on the second or on the left side where there's only 2, you're only going to have a superior and an inferior. So superior and inferior. You're not going to have a middle. The reason for that is because the left side of the left lung, not the left side of the lung, but the left lung actually makes room for the heart. So if you remember from our heart chapter, our heart is a little bit left leaning. So it leans to the left a little bit. And so because of that, because the heart takes up more space on the left side, we have a little notch right here to make room for it called the cardiac notch. So if you look over here on this diagram, it actually labels it the cardiac notch. Actually, I think I highlight it, so I should probably not do that. There it is, cardiac notch. So the cardiac notch is that little space right there that makes room for the heart. So that just means that the left lung has less lung tissue. So we just only have 2 lobes, a superior and inferior lobe. The right side, the heart does not take up as much room on the right side, so it has enough tissue to make 3 lobes, your superior, middle, and inferior lobe. Other things about the lungs that you should know is the apex. So now we're back. So remember from the heart, the base was at the top and the apex at the bottom, which is kind of backwards. For the lungs, we're back to normal. Apex is the point at the top. The base is the larger portion at the bottom. So base at the bottom of the lungs, apex at the top of the lungs. Another thing that your lecture notes mentions is the costal surface. And I don't think your textbook mentions it. So the costal surface is just the surface of the lung where the ribs press up against it. Okay, it's not going to be down here because down here they're a little bit posterior, so the ribs don't really press up against them as much. So this top portion here is going to be the costal surface where the lungs press up against the ribs. Okay. Another word you should know is the hilum. The hilum is just a space within the lung tissue. It's not even within, like it's an absence of lung tissue there, it's essentially just a passageway to allow your bronchial tubes and your blood vessels to flow through. So again, it's just a space created by the lungs in order to allow for a passageway of the bronchial tubes and the blood vessels. Okay, Next, we want to talk about the stroma. We'll actually talk about stroma a little bit later in respiratory 1, but the stroma are cells of the lungs that are not involved in gas exchange, so it's not moving oxygen or carbon dioxide. Instead, they're for the outside of the lungs and actually within the lung tissue as well. But they're there to make elastic fibers. So we'll talk a little bit later about something called compliance, and compliance is essentially the stretchiness of the lungs, which is necessary to allow the lungs to inflate and then recoil back to their original size. So the stroma are the cells of the lungs that make the elastic fibers that allow the lungs to expand in order to bring in more air. What's different about the stroma is that the stroma is supplied by our systemic circuit, while our alveolar capillaries are supplied by the pulmonary circuit. So essentially what that means is that the deoxygenated blood that enters the right side of the heart is going to go out through the pulmonary trunk and pulmonary arteries to the lungs. And then right there at the lungs is where the capillary pulmonary capillaries are going to line up with the alveoli to create that respiratory membrane to allow the exchange of gases. But that's not how we supply the stroma of our lungs. The stroma of our lungs, in order for us to get oxygen and nutrients to those cells that are making the elastic fibers, because they're cells living just like any other cells, and they need to receive oxygen. How they receive oxygen is that the gas exchange at the respiratory membrane occurs, and then that oxygenated blood gets returned back to the left side of the heart, the pulmonary veins. It goes to the left atrium, past the bicuspid or mitral valve, to the left ventricle, out the aortic semilunar valve to the aorta, and the aorta is going to send that blood out to the distributing arteries. So remember, you go elastic arteries to distributing arteries, and those distributing arteries are going to eventually approach the lungs and give oxygen nutrients to the stroma. So again, pulmonary circuit, that's where the gas exchange occurs between the alveoli and the pulmonary capillaries. But in order to supply the stroma with oxygen and nutrients, it's going to need to take the systemic circuit. So that blood at the respiratory membrane, when we pick up the oxygen, it has to go through the left side of the heart and then out the aorta, and then eventually make its way back to the lungs to supply the stroma with oxygen and nutrients. So I hope that made sense. Okay. And as far as your autonomic nervous system goes, it is your sympathetic nervous system does bronchodilation. Now, this is a little bit different than blood vessels. With blood vessels, sympathetic cause vasoconstriction. And that was vasoconstriction body-wide, but the areas that need it would be dilated. For sympathetic nervous system, when it comes to the respiratory system, because in sympathetic activation, you're in your fight or flight mode. So you want to either fight somebody or be able to run away very quickly. When that system gets turned on, your bronchioles are going to dilate in order to bring in more air, which means more oxygen, which means more energy eventually to make more ATP, or means more oxygen to react with glucose to make more energy or ATP. And then we have that energy to either fight or flight. So sympathetic nervous system is going to dilate your bronchioles, while on the opposite end, when you're in your rest and digest activation, your bronchioles are going to constrict and they're going to go back to their original size, because you don't need to move that much air if you're not really doing much activity. And then pleura, this should be very much review. So you should know that your parietal pleura is going to be the layer of your serous membrane that lines the cavity that it sits in. Your visceral pleura is going to be the layer of the serous membrane that actually touches the lung tissue. And then the space in between those two layers is called the pleural cavity. And that's where you're going to have serous fluid that's going to keep those two layers and allow them to slide past each other versus rubbing against each other. Because the dry rubbing could be painful. We'll talk about that in a second. You want a film of fluid in between those two layers, so those two layers will slide smoothly next to each other as the lungs expand and recoil. Okay, so two clinical aspects when it comes to your pleura, or your visceral and parietal pleura, your serous membrane. First, we'll talk about pleurisy. Pleurisy is it's when your pleural membrane, your serous membrane, your visceral and parietal pleura, when they get infected and become inflamed, and if they're inflamed over a period of time, they'll become roughened. And then what happens is when they become roughened, you're going to have friction. So now they're inflamed and now they're hard, and that serous fluid is not going to be doing much there. You're probably going to have less of it. And because your membrane is hardened now and not making as much fluid, you're going to have friction occurring, and those two layers are now going to rub together instead of sliding against each other. They're going to rub together, and that rubbing of those two layers together is going to cause a stabbing pain that's very painful. So again, that friction, okay, is going to cause them to rub against each other harshly, which is going to cause a stabbing pain in your chest. So causes of that are going to be infections, especially infections that lead to pneumonia. Obviously smoking as well, pulmonary embolisms. If you have autoimmune disorders that cause a lot of inflammation, like lupus or rheumatoid arthritis or HIV, lupus is a big one, but if you have an autoimmune disorder that causes inflammation, then you may be susceptible to pleurisy. If you have lung cancer, because you're going to have damaged tissue, you may have pleurisy. Tuberculosis, which is also damaging to the lungs, can cause pleurisy, as well as just trauma to the chest can also cause pleurisy. Sometimes pleurisy, because it is inflamed tissue, that inflamed tissue can actually eventually create excess fluid, and that's what we call pleural effusion. So when it's due to pleurisy, I should say that. When it's due to pleurisy, when this pleural effusion or this excess pleural fluid is due to pleurisy, what happens is that excess fluid will then separate the two layers from each other, which at first will relieve your symptoms. Because again, remember pleurisy, they're rubbing up against each other, but once you start to accumulate fluid, those two layers are going to start to come apart from each other, which again, it can relieve your friction pain for a while. Relieves pain from friction. However, similarly to cardiac tamponade, that fluid is going to build up against the lung tissue, and it's going to make the lung tissue hard to inflate because there's going to be this opposing pressure on top of the lungs, and it's going to make the lungs harder to expand. So pressure against lungs makes breathing difficult. And when I say breathing difficult, I mean really just the expansion of the lungs. It's going to be hard to bring in new air if you can't expand your lungs because there's this opposing pressure of fluid. Other risk factors for pleural effusion include smoking, which we already mentioned, alcohol, so drinking as well. And then also if you're exposed to asbestos, that can lead to pleural effusion as well. And if you do have pleural effusion where you have this opposing pressure on the lungs and the lungs can't properly expand, it can eventually lead to atelectasis. Can cause what's called atelectasis, and we're going to talk about atelectasis in respiratory 1, and this is lung collapse. So because of the opposing pressure on top of the lungs, due to the excess fluid around it, it could eventually cause that lung to not be able to inflate at all anymore, and it collapses and becomes very small, comparatively small. And I think that's it. All right, so that is it for our pre-respiratory little lecture. I hope this is helpful because in semesters in the past, I just had students just reading through their textbook to find these answers. So essentially you could, to do this assignment, you could just look it up in your textbook as well. But I hope that this is a little bit easier than having to look through the textbook for answers and looking through your lecture notes for answers. So that's it. I will see you guys in respiratory 1.